Welcome to the Rocky Mountain MS Center's webinar series. This webinar will feature an overview of the diagnosis and treatment approach in stiff person syndrome spectrum disorder. Stiff person syndrome spectrum disorder is studied and treated as part of the MS Center's work in our autoimmune neurological diseases, a collection of diagnoses closely related to multiple sclerosis. Our presenter today is Dr. Amanda Piquet. Dr. Piquet is a graduate at Penn State University School of Medicine and completed her neurology residency at Harvard's neurology program at Massachusetts General Hospital and Brigham and Women's Hospital. She completed a neuroimmunology autoimmune neurology fellowship at the University of Utah. Dr. Piquet sees patients with autoimmune neurological diseases, multiple sclerosis, and other inflammatory diseases of the central nervous system. This webinar features a lot of important information. If you missed something on a slide or want to hear it again, we are recording this webinar and it will be archived on our website at mscenter.org so you can play it at any time. All live viewers will get the recording automatically sent to them. You will also receive a link to our evaluation survey. Please take a few moments to fill this out to help us improve future programming. Today's presentation is for informational purposes only. All decisions regarding treatment and medications should be discussed with your neurologist. We'll reserve time at the end to answer questions from the audience. Please submit your questions at any time by typing them into the Q&A box on your screen. We will answer as many questions as time allows. With that, I'll turn it over to Dr. Piquet.
All right, great. Well, thank you and welcome everybody. And thank you, Kelsey, for that introduction. Also, thank you, Kelsey and the rest of the Rocky Mountain MS Center for arranging this webinar so we can all meet today. I am going to take a moment here and share my screen. So you might see me disappear off the camera. Just bear with me. All right, great. Everyone should be seeing the slide presentation here. So welcome again. This is a patient education webinar for stiff person syndrome spectrum disorder. Again, I'm Amanda Piquet. I'm an associate professor of neurology and director of the autoimmune neurology program at the University of Colorado. And in this next hour, we're going to review some basics about stiff person syndrome and treatment approaches. We will have a video about a patient's story with stiff person syndrome, and then we're going to get into the Q&A. Just as Kelsey had mentioned, please submit some additional questions through the chat option. We also have some questions that were submitted with registration as well, and we'll be starting with those. All right, so what is stiff person syndrome? Well, stiff person syndrome is a rare chronic autoimmune neurologic disorder that causes central nervous system hyperexcitability, and it leads to symptoms of these episodic muscle spasms and stiffness. This can be triggered by noise, touch, sound, emotional stress. This disorder is thought to affect about 1 in a million people, although large-scale epidemiology studies are lacking and misdiagnosis is common, therefore making an accurate estimate on incidence and prevalence difficult. Currently at the University of Colorado, we do have an epidemiology study that's underway looking at the incidence and prevalence within the UC Health system. And this study is being supported in part by the Rocky Mountain MS Center. Stiff person syndrome has been described as a spectrum disorder because there's variable ways patients can present, and we call these clinical phenotypes. The severity of the disease can range from a stiff limb all the way to a perm presentation, which is this severe muscle rigidity, and myoclonus, which is an involuntary jerking movement. Often in this severe form, patients can be hospitalized. And then there's the classic SPS, which often involves stiffness in the trunk and torso, leg involvement greater than arm involvement. However, again, this is a spectrum of presentations, and each individual can be different. Patients can have signs of cerebellar ataxia, which presents with dizziness, balance issues, coordination issues. And so this might be described as a SPS plus phenotype when part of an overall clinical picture of stiff person syndrome. Separately, this can be described as a distinct phenotype called cerebellar ataxia, and that is often seen in the setting of high GAD65 antibodies. Now, the diagnosis is a challenge and misdiagnosis is common. The diagnosis is based on clinical presentation, so how patients present and their history, electrophysiologic or EMG studies, and antibody testing. Patients are most commonly reported to be GAD65 antibody positive, and this is GAD65 antibodies at high titers, which we'll talk about in a bit. But there are other antibodies that have been associated with the disease as well. And there's a small subset of patients that do not have a positive antibody. And these patients are identified as seronegative stiff person syndrome. And that can be even more of a challenge to accurately diagnose. EMG can be very helpful in this context. Additional testing often includes studies that help rule out other causes of neurologic symptoms. So for example, that would include a lumbar puncture where we can look for other types of inflammation. We can also evaluate for GAD65 antibodies to help in the diagnostic workup of stiff person syndrome. When looking at imaging such as MRI, including the brain and spine, this is often normal in stiff person syndrome, but again, very important to do because it rules out other mimics that can look like stiff person syndrome. And then genetic testing is sometimes considered as well to look for other mimics such as neurodegenerative disorders or genetic mimics. Stiff person syndrome causes central nervous system hyperexcitability, and that leads to these episodic muscle spasms and stiffness. As mentioned before, this can commonly be triggered by noise, touch, emotional stress, or it can occur spontaneously. With this central nervous system hyperexcitability, there's essentially a problem with putting the brakes on the nervous system. So this figure from Dr. Delakis's paper cited below illustrates this dysfunction in those neurologic brakes, and that's basically with this impaired GABAergic signal seen here, in which the GABA receptor releases inhibitory signals in the brain and spinal cord. When these inhibitory signals are impaired, the brakes are impaired. So basically, this is the signal that puts the brakes on the nervous system. And when it's not working properly, you get these signaling malfunction down the spinal cord, allowing for continuous firing at the muscle, leading to muscle co-contraction. And so that basically means you have muscles contracting on both sides. While the underlying pathophysiology in stiff person syndrome is largely unknown, it's thought to be related to this GABA receptor, as we just discussed on the previous slide. Looking a little bit closer at the GABA receptor, you can see here on this picture that there are potential binding sites for antibodies that are commonly recognized in stiff person. Again, GAD65 antibodies are the most common. And GAD serves as the rate-limiting enzyme making GABA from glutamate. GABA is an inhibitory neurotransmitter, again, a transmitter that puts on the brakes, and it's critical to that process. GAD65 antibodies are the most commonly identified antibody. There are other antibody sites included on this slide. So for example, amphiphysin, GABA-A, although this one's exceedingly rare and less clearly defined, glycine receptor antibody, which is the second most common antibody that we see after GAD65, and Gefferin, which is another rare antibody and not commercially available for testing. DPPX has also been described in stiff person syndrome. This one, again, very rare and often causes symptoms outside of that classic stiff person syndrome phenotype, including encephalitis, which can cause memory problems and confusion. The most comprehensive commercial testing to date at the time of this presentation is available at the Mayo Clinic. There is a separate stiff person syndrome evaluation or antibody panel that includes, that you could see here on this slide, includes everything in the blue circle. If patients present with more of that cerebellar ataxia or balance issues, sometimes it may be appropriate to test a little more broadly, in which case they also have something called a movement disorder evaluation. And you could see in this circle here, everything that's included in that antibody panel. Importantly, GAD65 is present on both testing panels. And equally important, glycine is not included in the movement disorder evaluation, at least as of today. And so that needs to be ordered separately. And so that's important for clinicians to be aware, because if a patient has a clear signs of stiff person syndrome and a hyperstartle reflex, it is important not to forget that testing. Oops, I forgot my circles. So this is the GAD65 and the glycine. So when looking at positive GAD65 antibodies, the titer matters. So the number that goes along with the positive test is important. This is a very tricky test to interpret, and it does require a physician who is familiar with the antibody testing to accurately understand the meaning of the test. And so this antibody can be positive in other autoimmune conditions, especially type 1 diabetes, but also seen with other systemic autoimmune conditions like autoimmune thyroid disease, as well as being detected at low levels at 8% of the general population. So we can see false positives in patients, and we can also see false positives in patients receiving IVIG, which is this intravenous immune globulin, often used in the treatment of stiff person syndrome, that are antibodies pooled from thousands of people. Hence, we can get these false positives. High titers of GAD65 are typically seen with neurologic disease, and the definition of what is considered high actually is dependent on where the testing is done. So different labs have different reference values and numbers. So you have to know where the antibody is being tested to accurately interpret whether or not it's a high or low titer. So outside of antibody testing in the blood, diagnostics often include this EMG procedure. Again, brain and spinal cord MRIs, mainly used to look for other causes of the neurologic symptoms, and lumbar punctures to look at spinal fluid studies. And this can include markers of inflammation, something called oligoclonal bands, as well as doing that same antibody testing in the spinal fluid as well, looking for those GAD65 antibodies or looking for those glycine receptor antibodies. The treatment approach in stiff person syndrome is multifactorial. It is aimed at symptomatic therapy as well as immune therapy. Many of the symptomatic medications are aimed at improving symptoms by improving the GABAergic neurotransmission, or basically putting those brakes back onto the nervous system. First-line therapies often include benzodiazepines. Commonly, Valium is used. Other anti-spasm agents like baclofen are often utilized as well. And medications like gabapentin, which is actually traditionally used as an anti-seizure medicine or a medicine used for neuropathic pain, can also be helpful given its target at the GABA receptor. Some patients may benefit from other therapies that are more targeted, like Botox. Now, it's very difficult to Botox every muscle, but if there seems to be a problem area, such as in stiff limb, perhaps Botox can be used to really target a specific muscle. Other supportive therapies that are often used and are essential in kind of the overall treatment plan are physical therapy, hydrotherapy, and psychological support. Stiff person patients experience severe anxiety and phobias often due to this fear of falling or even just completing simple tasks. And having this psychological support can be very helpful. In terms of hydrotherapy, I did leave a little link here if you are tuning in from the Denver metro area. The Rocky Mountain MS Center does have some locations in the area for hydrotherapy. And if you're one of my clinic patients, I'm often handing this information out at the appointments as well. Now, let's talk a little bit about the immune therapies. I just want to be clear that there are no FDA-approved therapies for stiff person syndrome at this point in time. Several immune therapies have been used in stiff person syndrome that are often utilized in other autoimmune diseases, including other autoimmune neurologic disorders. IVIG appears to have the most benefit, but is based on limited studies. It is often our first go-to, so our first-line therapy for stiff person syndrome when it comes to immune therapies. Rituximab is often used as a second-line therapy. Again, the data is limited, and there was one small trial that failed to prove its benefit, which we're going to talk about in a bit more. Other therapies that have been utilized include plasma exchange, other immune therapies, pill forms such as azathioprine, mycophenolate, which is also called Cellcept, and less commonly, but perhaps for more severe cases, cyclophosphamide or Cytoxan. Third-line therapy may include autologous hematopoietic stem cell transplant. Importantly, this is done on a research basis. So this is an example or one of the early publications showing IVIG is well tolerated and effective for patients with stiff person syndrome. This is another study that has continued to support the effectiveness of stiff person syndrome. However, over time, as you can see here highlighted, there does appear to be this diminished benefit as the disease progresses, and really highlighting that, we need to identify better and more effective therapies in stiff person syndrome. Now, this diminished benefit to IVIG, at least described in this study, was over a median time frame of about 3 years, and it was not everyone, but it was a little less than a third of patients at close to 30% where we see this diminished benefit. In regards to rituximab, this is the study that was published that was a double-blind, placebo-controlled study of rituximab in patients with stiff person syndrome. At the end, rituximab failed to show a lack of efficacy, but there were a few things in the study that perhaps could have been contributing to this, because there was a subset of patients that did appear to have a benefit. And so the placebo arm in this study there was a fairly large placebo effect, which dampens kind of the results from the rituximab arm. There was also a concern about how it was studied, so using a scale that maybe wasn't as effective. So we this study used basically, how stiff the muscles were, but that might have been insensitive to picking up smaller improvements. And so I think we've learned a lot about this study. Rituximab is still very commonly utilized as a second-line therapy after IVIG, and it just needs to be studied more. So here we're going to move on to our patient story.
Yeah.
Hello, my name is Rose Merrill. I am 23 years old and I was diagnosed with stiff person syndrome in 2021. I'm really excited to be here, and I hope to help raise awareness about stiff person syndrome and hopefully get people diagnosed earlier and find better treatment options for us.
Awesome. What were your first symptoms of SPS?
So some of my first symptoms of SPS were, at first I was just really clumsy and had a very strong startle reflex, and I was unusually strong. As things progressed further, I started having a lot more stiffness, and I would have very bad spasms, which I at that point wrongly described as conscious seizures.
How long did it take for you to receive a diagnosis?
From the time I started searching for answers to diagnosis was around 6 years for me, although I did have some symptoms earlier than that.
Did you have any delays in your diagnosis?
Yeah, I was originally misdiagnosed with a psychiatric condition called conversion disorder, and because of that, I mainly started seeking psychiatric treatment instead of medical treatment, and that very much delayed my diagnosis.
Why is early diagnosis so important to you?
So when someone is diagnosed early, there are often treatment options that are safer or available for people less progressed in the disease, and I really would like to have people have better treatment outcomes and longer lives and better overall lives.
What struggles have you had navigating the medical system earlier in your disease?
So before I was diagnosed, often paramedics would think I was faking. They would sometimes go out of their way to hurt me to try to prove I was faking, and it was very distressing, and I stopped seeking a lot of medical care after that. And it was very difficult. Sometimes when I saw doctors, they were very dismissive of me. They claimed it was 100% anxiety, and I would be very frustrated because I was working so hard in my therapy and yet getting nowhere, or really getting worse.
And how have things changed now that you've gotten your diagnosis and are seeing Dr. Piquet?
So people have started treating me a lot better. I've gotten a lot more medical treatment that relates directly to my disease. I now have treatment plans for if I have a bad spasm and need rescue medications, and so that helps me get help a lot faster when I need it, and a lot less dangerous situations arise from not getting the treatment I need.
What is the single most important symptom or struggle that you would like your doctor to understand best about your disease, or anyone around you?
So I would like everyone to understand that stiff person syndrome can, especially in the early stages, very much present as a psychiatric condition. And while there are psychiatric aspects of the condition, it's also important to recognize it is a physical condition and needs physical treatment as well. And so any treatment approach should be aimed at addressing both those factors and be a more holistic approach.
Tell me about your experience at the King Adult Day Enrichment Program, or KDEP. How has it helped? What do you enjoy?
So KDEP has really given me a sense of community. Stiff person syndrome is still considered a pretty rare disease, and so we often don't meet many people like us. And so while KDEP doesn't have anyone else with stiff person syndrome, we have a lot of people who face unique challenges, but sometimes very relatable challenges. And therefore, I feel like I have a community of friends who really understand me.
Is there anything that support partners have done that have been particularly helpful to you, or anything that you'd like to share with support partners listening about how they can help someone and support someone living with stiff person syndrome?
So what I need most from those close to me is just emotional support, being able to listen to me and understand and come from a place of empathy about the struggles I'm facing, but also encourage me to keep going and keep fighting. It's also really helpful if support partners know what to do in case a spasm arises, especially if you can't communicate. Come up with alternative forms of communication so that you can still ask for and know what your partner needs when they are in a spasm.
Is there anything else that you want to share with other people who are living with stiff person syndrome?
When I was first diagnosed with stiff person syndrome, it was extremely difficult to get through mentally. But over time, I began, learning how to manage the disease, the symptoms, and the psychiatric comorbidities. And even with stiff person syndrome, you can really live a wonderful life. It may take some adaptations. It may take a lot of advocating for yourself and what you need, but you can develop hobbies, you can make friends, you can have a community, and you can have a really great life, even with stiff person syndrome.
Well, thank you so much, Rose, for sharing your story with us today. So with that, we're going to dive in first to some questions that were submitted prior to the webinar. The first question is, why are we now just discovering the disease? Was it previously misdiagnosed as MS? So stiff person syndrome was first described in 13 patients at the Mayo Clinic in 1956, and it was termed stiff man syndrome at the time. We have come a long way now using kind of this terminology of stiff person spectrum disorder. We know that it does not just occur in men, it occurs in women as well. In fact, probably more common in women, as we see with other autoimmune diseases. And while we have come a long way with recognizing the disease, we still lack formal consensus criteria. Now, there are publications out there amongst experts. We kind of do rely on that clinical presentation, the EMG, the antibody testing, as I described, but the consensus, there is no formalized criteria based on consensus committee. There is also a lack in FDA-approved therapies, and hopefully with continued research, treatment options will improve in the future. Now, regarding the question, can stiff person syndrome be misdiagnosed as MS? The answer is yes. This can sometimes occur, but often in atypical MS presentations. Here's a publication by Dr. Newsom's group that did describe 5 patients with stiff person syndrome who were initially diagnosed as MS. Key points here are the need for adequate review of brain MRIs, spinal MRIs, and spinal fluid studies, which can really help differentiate these conditions. As I had mentioned before, brain MRI, spine MRI tend to be normal in stiff person syndrome. When you look at the diagnosis of MS, those imaging modalities are crucial to the diagnosis in MS, where you see the classic demyelinating lesions. So this kind of gets in a little bit more to the next question: how are stiff person syndrome and MS similar? Well, both stiff person syndrome and MS are chronic neuroinflammatory disorders. But the underlying disease process, kind of what we call pathophysiology, is different. Spasms and pain can occur in both stiff person syndrome and MS. With SPS, the spasms tend to be a little more intense, appear a bit differently in terms of the report from patients and what we see on our clinical exam and clinical presentation. However, many of the therapies, in terms of symptomatic therapies targeting neuropathic pain, do overlap in these two diseases. Unlike multiple sclerosis, as I had mentioned, we do not see these classic demyelinating white matter lesions on the brain and spinal cord with stiff person syndrome. So how do other conditions like diabetes, epilepsy, thyroid disease affect the severity of stiff person syndrome? Well, just taking a step back, with stiff person syndrome, it's common to see these other coexisting autoimmune diseases, the common ones being type 1 diabetes, thyroid disease, vitamin B12 deficiency. It's important, and we typically do this in the clinic, to screen for these disorders at the time of diagnosis. And then often we're rechecking these labs on an annual basis. And it's important to treat these coexisting conditions because that can impact the overall health of patients, can impact the neurologic symptoms and disability patients may have if these diseases go untreated. Just for, an example, vitamin B12 deficiency, if you are severely deficient in this, it can actually cause neuropathies, making neuropathic pain worse. So that could be an example of how that could make some of the symptoms that we see coexisting with SPS worse. Autoimmune epilepsy may occur and has certainly been described with GAD65 antibodies, and treatment with anti-seizure medications may also be needed in addition to immune therapies. And with that, I'd just like to thank everyone for tuning in, and we reserved the last half of this webinar for some live Q&A.
Thank you, Dr. Piquet. You guys can continue submitting questions. I do have a couple more that were submitted ahead of time. Could you go into a little bit more about kind of some of the treatment methods for stiffness, particularly if somebody is in crisis, or if there's anything to prevent the spasms?
Yeah, that's a great question. So you're talking about symptomatic therapies, it sounds like, similar to when we see the muscle spasms, we kind of reach for our standard symptomatic treatment is those benzodiazepines. They can be really helpful when we end up in kind of this uncontrolled spasm or an SPS crisis. Many times, with the standard treatment, we'll use oral benzodiazepines, but sometimes in these extreme circumstances, we need some sublingual or liquid for patients. Very, very rarely, there's other routes that we can use, like intranasal administration that sometimes we use with seizure disorders.
I think you maybe answered this when you were talking about the similarities and differences between MS and SPS, but is it possible for someone to have both of those conditions?
That is a great question, and I almost think I know who asked that question. This is it would be exceedingly rare to see these conditions together and very unlikely. Generally speaking, if we're working up a patient that we're concerned about SPS or MS, really the MRI is super, super helpful in differentiating these conditions. That said, I do have one patient that really does meet the criteria for both. And, if SPS was a 1 in a million diagnosis, I do not know how rare that would be to have both. Exceedingly rare.
At what point does a contracture become irreversible?
Mm, that's a good question. Generally, we do see that it is not irreversible where the muscle spasms are episodic. And when you do have a severe spasm, it's really hard to kind of release. But, similar to what we can see in other neurologic disease with ongoing disability and spasticity, if it's severe, we might see contractures that become permanent. Uh, this is when we're concerned that may become the case in a very specific area. That is where Botox may be helpful in releasing that before it can cause too much long-term disability.
Can you talk a little bit about the variability of symptoms? Are there symptoms that kind of are all the time? Is there a pattern to how often spasms happen?
So everyone's going to be a little bit different in their presentation. So I think it's hard to just say kind of across the board, spasms occur generally this many times a day, and this is how everyone progresses. That being said, I think the general trend is that when patients are not treated, we can see these spasms in the beginning, perhaps be more episodic, perhaps be more triggered by certain provoking factors, loud noises, bright lights, certain phobias, you know, uh, we can see that. And then over time, we can see as the disease progresses, perhaps maybe these spasms become more frequent, less provoked, where we can see unprovoked spasms and nocturnal spasms where it's disruptive to sleep.
Do people with SPS ever complain of an internal vibration?
I've heard that a lot, but not just with SPS. I've seen that with other neurologic disorders as well, such as MS. And really, it's this like your brain kind of misinterpreting that sensory response. It's actually fairly common to see, central nervous system dysfunction, SPS, MS, but I've also heard that described sometimes in small fiber neuropathy as well, or neuropathies where you have this sensory dysfunction. But yes, that is a real thing that I've heard.
Can a person present with spasms and unusual hearing vestibular loss?
Hearing loss. I don't typically think of hearing loss in SPS per se. There's certainly other neurologic diseases that sometimes coexist with SPS, like, for instance, I just mentioned small fiber neuropathies or neuropathies that, sometimes we can see hearing loss in those conditions. But I think if hearing loss is a big component, looking for alternative causes would be important to work with your neurologist on. That said, if you're talking about just feeling unbalanced, because you said vertigo, I think, that could be part of what we see with that cerebellar involvement in that SPS plus phenotype that I had described.
Are there periods of remission like we see in MS, or is it just slowly progressive?
That's a great question. And I don't think I have all of the information for that. And again, I'm going to use the same saying, everyone's a little different. There tends to be less discrete relapses like we see in MS with SPS. I think patients in the beginning often do, or at least some patients have a very good response with this combination of symptomatic therapy and immune therapies. And as you can see in that IVIG paper that I showed, a lot of patients do have a benefit. It's just some over time that benefit may diminish. And so that can look similar to sometimes what we see in multiple sclerosis, where early in the disease, we're targeting that inflammation, we're using disease modifying therapies, so other forms of immune therapy, and we can really get the disease under control and not see any relapses, and patients are doing fairly well. And then as time goes on, some patients do turn into this more progressive MS picture, or secondary progressive MS. And so there are some similarities. I think the timelines may be perhaps a little bit different, but we continue to study stiff person syndrome and continue to learn more and more about the disease.
Are there any precautions for PT, certain techniques that would help with the spasms, or is PT primarily addressing modifications and assistive devices for balance, gait, safety?
So physical therapy can be a combination of both those things. It's really nice when we can find a physical therapist that, although very rare, familiar with SPS, that would be kind of, the best scenario. But even just physical therapists who are familiar with neurologic disability and dysfunction, and then focusing on things like balance, strength training, stretching, but you have to be careful because you don't want to overdo it and induce spasms. And then the other part of physical therapy is exactly as you said, help with assistive devices. That is also very important, obviously.
Can MS turn into SPS or vice versa?
No, MS is its own distinct clinical disease and is a different driver of the disease. What you can see, and I have seen patients that perhaps have features that kind of look like stiff person syndrome, but you do the brain MRI and the spinal cord imaging, particularly the spinal cord imaging. If you have lesions in the spinal cord, you can have very similar symptoms to what we can see with SPS, just from spinal cord dysfunction, things like muscle spasms, things like neuropathic pain.
If someone has both SPS and Sjogren's,
Sjogren's, yes.
is muscle and joint pain can be especially confusing. Is there a way to sort out whether it's SPS or Sjogren's?
So a stiff person syndrome, you can see overlap and coexist, like I said, with other autoimmune disorders, including rheumatologic disorders. Sjogren's syndrome, kind of the classic features there, dry eyes, dry mouth. Usually joint pain is not so much Sjogren's, but other rheumatologic diseases, we can kind of see that as well, like rheumatoid arthritis. And so, sometimes it can be difficult, maybe perhaps to pinpoint every single kind of pain syndrome or muscle spasm, what's causing it. I don't typically think of these rheumatologic disorders causing a lot of diffuse muscle spasms in the same characteristic that we see with stiff person. Really, rheumatologic disease is kind of focused on the joints. I think if you have a complex picture like this is why multidisciplinary care is essential. So seeing a neurologist and a rheumatologist to make sure the diseases are adequately treated and symptoms are addressed.
As IVIG efficacy decreases in SPS symptoms, is it important to continue it for immune support?
So IVIG is used in the management of stiff person syndrome. So Unfortunately, with this being a chronic autoimmune condition, often patients require long-term use of IVIG. I think that's what the question Kelsey was asking. Do you mind repeating it? I don't know if I answered that.
As the effectiveness decreases, should one consider continuing?
Oh, I see. If it's not as effective anymore. So sometimes the best way to actually tell if the IVIG is, even though it's not working as well as it used to, if it's still helpful, is no one's enthusiastic about this, but sometimes taking an IVIG holiday. And so if you take a break from the IVIG and have a discrete worsening and then resume it, and that's sometimes a way to tell if it's still having a benefit.
Is
No exact science, sorry.
is repetitive speech and talkativeness associated with SPS?
I haven't seen that. That's an interesting question. I don't know how to answer that one. I'm sorry.
And we had a request to please let us know where the disease is usually seen first again, or how it generally presents in the early time.
Yeah, so again, everyone's going to be a little different here. Early symptoms, sometimes we see that stiff limb or one limb being involved where we have kind of muscle spasms, cramping, stiffness. When it does start, if it's just one limb or if it's it tends to be a leg in the classic phenotype or both legs being involved. Another common area for it to begin is in the trunk. So back spasm involvement, it then can progress to affect walking or what we call gait dysfunction.
What is the best way to find a specialist for SPS?
That is a great question. And I think as a field, we need to do better. So I know there is a new organization called the Stiff Person Syndrome Research Foundation that was founded in 2019. And they have some great information about stiff person syndrome directed for patients on their website. I don't think they have it like a referral network on there to date, but I believe that's something they're working on doing. And so if we let us look into that, and perhaps maybe I can with this webinar, Kelsey, we can advertise that if those resources do exist. Certainly, we are open to seeing consultations clearly at the University of Colorado for stiff person syndrome. There are other, big centers around the country that see stiff person syndrome. But it is a rare disease and it is a small group of specialists that really focus on SPS, but looking at those institutions that have big centers for autoimmune neurologic disease are probably a good first start.
Can IVIG also be used to treat MS?
So IVIG is not considered a effective therapy for MS, and there have been I don't have them off the top of my head, but studies and trials that showed it was not effective.
Can you give some suggestions for how a patient might handle a physical therapy office that wants to deny continuing therapy based on the fact that there is no progress?
Oh, insurance, the bane of my existence. So I mean, ongoing physical therapy is necessary. Yes, I say this disease is a progressive disease, but everything we can do to maintain neurologic function and prevent ongoing disability is key. So I think some of these rules are sometimes a little bit silly, and usually it just takes the referral from your neurologist to kind of say why physical therapy is needed and for ongoing care.
Kind of a two-part question. Has fasting been considered a way to deal with SPSD? And on that note, are there other lifestyle things that folks should be considering to maximize health?
So there are no studies that I am aware of with SPS and fasting. I'm assuming this is kind of intermittent fasting that you're talking about. It is certainly an interesting concept. I do believe there are lifestyle changes that are good for all neurologic diseases, not just SPS, but things that, are proven to be beneficial in other neurologic diseases like multiple sclerosis. So that includes, a nice heart healthy, well-balanced diet. That includes exercise. That includes avoidance of bad habits like smoking. We know with MS and other neurologic diseases that neurologic disability is worse with smoking. So I have no doubt in my mind that that's probably the case with SPS as well. Same thing with obesity, that would most likely, we would expect that to make neurologic disability worse as well. And that has been shown in MS that we can see obesity worsening disease disability and progression in those situations. So I think taking a step back and thinking about neurologic wellness, neurologic health, whole brain health, doing these things in SPS make a lot of sense.
Is back pain a common complaint of SPS?
Yeah, so one of the early symptoms, like I said, when we see these muscle spasms and stiffness come on, it's usually legs, back, trunk first. So back pain can be, back pain's common. If that's the only thing, that would be unusual for SPS, but back pain can certainly be, one of the presenting symptoms that we see as well.
What about vision problems?
Oh, I feel like someone's reading my papers out there. Yeah, so vision, yes. We can see different vision problems. So first, cerebellar dysfunction. Remember I said balance, coordination, walking, that can be signs of cerebellar dysfunction, where the cerebellum is the back area of the brain. It's a coordinating center of the brain. So not only does it coordinate your movements with the arms and legs and walking, it also coordinates your eye movements. And so if you have cerebellar involvement, you can see dysfunction in coordinating your eye movements, and that can present with visual symptoms like double vision or eye movement problems. It has been described, and we had published a paper with a group of patients from the University of Colorado, as well as partnering with the University of Utah, that we found patients with glycine receptor antibodies did have some different, outside of double vision, some different visual symptoms that we were describing, and they almost seem kind of similar to what we can see with migraines. One of the fancy terms that we use is palinopsia, which, if you think of those old movie screens where the frames move very slowly, that's what your vision's doing when you're looking around. And it tends to be constant, not coming and going like we can see with migraines, which often have an associated headache as well. But that's a very interesting question. And I'm sure, Kelsey, there's a way to, if someone really wants to dive into the literature, we could share that paper.
Yeah, we will. Can we add it to our website?
Yeah, we can add it to the website.
Excellent. That is almost all of the questions that we have submitted for today. I thought maybe we could just end with your thoughts on what does the future look like? Is there a cure? Hopeful? Just future thoughts.
Yeah, so first I just want to thank everyone for asking such thought-provoking questions. I'm glad we had the time to address almost all of them, it sounds like, and taking your time out on a Friday morning to join us on this webinar. I think maybe being an optimist, the future is bright. So, we have, like I said, come a long way learning about this disease, and there is a lot of interest in the field to learn more. And with increased recognition of this disease, with adequate diagnosis of this disease, eventually, things like better therapies will follow. And I do have the opportunity to be involved with the Stiff Person Research Foundation, and I know they are putting together things like a patient registry. And so interest in doing research projects like that, we're going to learn more and more about patients, about the disease. And like I said, that's going to lead to better therapies in the future because we'll be able to develop therapeutic trials. So the future, I think, is bright.
Wonderful. Thank you so much, Dr. Piquet, for your time today. Thank you, everyone, again, for your questions. They were fantastic. We will be sending out this recording, and in that email, we will include a link to the section on our website where all of our stiff person syndrome and related neurological condition information is. So again, thank you, and have a great rest of your day.
Yeah, thank you. And please fill out the survey so we can do this more and do it better.
Thank you.
Thanks. Bye.